Okay, as people are joining, I want to say welcome to everyone who is joining us today, and thank you for joining us. This is the webinar on child welfare and early childhood, cross-systems collaboration to improve outcomes for young children and their families. This is the third webinar in our 5-webinar series, and the topic for today's webinar is prevention. I'm your moderator, Cynthia Tate, with the BUILD Initiative. We're going to continue to let people in, and when the entries slow down, we'll go on ahead and get started. Again, thank you for joining us. We're really glad you're here. This is an exciting topic, and we think you're really going to both learn a lot and enjoy the conversation. Okay, we're going to go ahead and get started. Again, thanks to everyone who has joined us today. Our numbers are still going up, so people are still continuing to join us. But we're going to go ahead and get started with our webinar for you today. So the objectives of the series are, first of all, to raise awareness about young children and their families who are encountering or involved in some way with the child welfare system. We want also to educate participants about the racial disparities in the family separation that's caused by child welfare involvement. And we want to promote opportunities and strategies for prevention for families and communities, and provide examples of cross-systems collaboration on behalf of our youngest children. So for those of you who have already attended some of these, you'll find that there is a similar structure as we have today, which is we have both an educational and foundational kind of presentation, and then we give you real examples of people who are actually doing the work on the ground. We want to do this because we want to make sure everybody knows that while we have huge challenges ahead of us, we do have some things that actually do work and that can be picked up and replicated. So for this particular webinar on prevention, we're going to learn what an effective or promising prevention system actually looks like in child welfare and other human services. We're going to learn about California's child maltreatment prevention system and Minnesota's community resource hubs. We're going to learn about Minnesota's promotion, prevention, early intervention continuum, and also about the relationship between child maltreatment and poverty. We're going to discuss the implementation of Washington's plan of safe care and the challenges and solutions in this very active collaboration between their Department of Children, Youth, and Families Office of Child Welfare Programs and Help Me Grow. Okay, we're seeing familiar names coming through on the chat. So just keep introducing yourselves, everybody. It helps us to know who's here. So I'm going to introduce the panelists to you. And I'm really just going to call their names and ask them to go on with a little bit of an introduction on where they are and what they do. So first, Sarah Holdener.
Hello, good morning from Washington, the West Coast. My name is Sarah Holdener. I work at the Washington State Department of Children, Youth, and Families, and I am the Help Me Grow lead here and a key partner in the plan of safe care work in our state.
Thank you, Sarah. Alyssa Copeland.
Good morning. Thanks so much, Cynthia. I'm Alyssa Copeland, also from the Department of Children, Youth, and Families in Washington, and I work in the Child Welfare Programs Division as the Intake and Early Learning Program Manager. And one of my program areas is the Plan of Safe Care work in our state.
Great. Thank you, Alyssa. Robin Jenkins.
Well, good afternoon from the East Coast, and thanks so much for letting me be a part of this amazing group. I work at Frank Porter Graham Child Development Institute at UNC in Chapel Hill. Our group specializes in helping organizations and systems bring evidence into them through implementation science, best practices, strategies, use of frameworks, tools, and those kinds of things. We are engaged out in California as one of our portfolio projects in helping them stand up a core practice model. And in a parallel responsibility, I became engaged in supporting their sort of child abuse prevention system reboot. And that's the part of the conversation that I'm going to be having today. I'm a clinical and community psychologist by training, and I've got a fairly long history in juvenile justice, child welfare, behavioral health, substance abuse, and the systems that serve those populations.
Thank you, Robin. Nikki Kovan.
Hi, everyone. Nikki Kovan. I'm at the Minnesota Department of Education. I'm the Early Learning Services Division Director here. PDG, our Preschool Development Grant, it operates out of our Early Learning Services Division. And I also have a rather extensive history in child welfare, in addition to my work in early care and education, having formerly been in leadership in our child welfare division as of just 2 months ago. So when you hear me talk today, I'll be talking about some of the data work that we did while I was in that division, and then also talking about our work here in early learning services in the Preschool Development Grant.
Thank you, Nikki.
Mm-hmm.
Okay, and Megan Waltz.
Hi, everyone. Megan Waltz. I currently serve as the Promotion and Prevention Supervisor in the Child and Safety and Permanency Division at the Minnesota Department of Human Services. Previous to that, I was the Prenatal to 3 Policy and Systems Advisor at the Minnesota Department of Health. So really a combination of public health and child welfare. It's good to be here. Thanks, Cynthia.
Thank you. So as all of you wonderful participants can hear, we've got a really dynamite team here for you today. So we hope that you really enjoy it. We're very excited to be here. So here's what we want you to know about how to participate. First of all, go ahead and introduce yourself in the chat. As you can see, a lot of people are doing that. Go ahead and do that if you haven't. And the second is to answer the poll question. So immediately following this slide, we're going to put up a poll. It's really just to help us to kind of get an idea of who's here. And it's a simple, straightforward poll, and we'll give you the answers right here at live time. And the third is to put your questions for the panelists into the chat or the Q&A. So the way that this is going to work is that once the panelists have completed their presentations, I will be given the questions from the chat and the Q&A by our build folks behind the scenes, and I will speak for you, and I will give the questions to the panelists, and we'll get some answers in that way. And then there's a survey at the end, because we always need to know what we did well and where we could improve. And so we'll have a survey at the end that we're going to ask you to complete. Okay, so we'll move on from here. Here's the poll. We want you to go ahead and just complete the poll. There's only about 4 or 5 questions. Okay, we'll just take another minute or so, let more folks complete the poll, and then Jonathan is going to show us the results. Okay, how about we look at those results now? Okay, so we've got about 14% of you are coming from the child welfare field, about 19% adjacent to child welfare, where child welfare is a priority population. 39% are in early care and education, and about 28% in other early childhood programs. So that's great. That's a really great distribution. And we asked the question next: how well do you understand the child welfare system in your state? We've got most of the people, 45, the largest percentage of people understand some. 33% said they understand a lot. So that's awesome, really awesome. And we've got 3% that are experts. So welcome. All right. And so we're about half and half on the percentage of people who know of change efforts currently underway in your state that are targeting children and families that are in child welfare. And we have about 45% that are not familiar with plans of safe care. So this will be a great learning experience. About 24% that are a little familiar, and about 9% that are very familiar. And we've got 1 person that is an expert. So welcome. All right. Thank you so much. We appreciate that. Now we know who's in the audience, and we're going to go on ahead and with our presentations, starting with Robin Jenkins. Dr. Jenkins.
Thank you, Cynthia, and thanks again for inviting me to participate in this. I'm anxious to learn from everybody and happy to share our journey together in California through the partnerships that we've been able to form there. So, boy, this is a long story, and I have just a few minutes to tell it. But if you want to go to the next slide, I'll do the best I can. My goals for participating in this is to sort of share with you some promising ideas for creating effective, sustainable child and family well-being systems. Notice that I'm steering away from this idea of child maltreatment prevention and leading into the whole world of what does it take to nurture and enable systems and environments where children and families are in a well-being scenario as opposed to reacting to risk or other factors. We're going to talk a little bit about what implementation science brings to the table in terms of key elements in supporting these systems. And then we're going to do some sharing around California's child maltreatment prevention sort of reboot that we've been calling it over the last couple of years. I want to also acknowledge my colleague, Renee Booth, who's joined us. She presented in the last Build Initiative webinar and is every bit my mentor and colleague in this work in California. So really appreciate the fact that she's joining us. I saw other California colleagues and partners in the journey sign on in the chat as well. So I'm coming at this as a humble participant and practitioner in the California space and not as an expert, so to speak. And so as the opportunity builds for participation from Californians and others, would invite their perspectives as well. So starting out, this sort of idea of what if we imagine communities as being more of an integrative approach to equity-focused child and family well-being systems. And what we mean by that is that the evidence we bring into the systems includes sort of this community and historical voice, lived experience, cultural and value-driven experiences, in addition to what we in academia and other systems sort of treat as empiricism, empirical findings, positivism that comes from European traditions. So this different paradigm that is building across the country really stems from the United States and the research literature opening up its mind to developing nations and other organizations and states and systems that bring a different view of what informs evidence in a community-based setting. And I think California is trying to do that. They're trying to take on this sort of equity-focused, trauma-sensitive lens. And there are a lot of different ways they're doing that, and I'll try to share a couple of examples. This different equity approached integrative process also sort of rearranges the equation from safety, permanency, and well-being, which is sort of the classic child welfare equation, to moving well-being to the front of the line, well-being, safety, and permanency. And then it sort of blends a really complicated set of frameworks and theoretical approaches into an overarching public health model. This includes things like adding developmental science, ecology and ecological approaches, and things that many of you are already familiar with, resiliency theory and protective factor theory, paying attention to social determinants of health, the race equity and ethnicity lens and lived experience, but with a real eye towards designing things across systems that embed implementation and prevention science evidence, and marry that with holistic supports, not just focusing on a child, but focusing on multi-generational supports and also multi-generational determinants of where things have gotten off track for those families where opportunity doesn't present itself for healthy well-being perspectives. So next slide, please. Okay, so when we think about designing implementation, it's an open system. We don't control the resources coming in and out, and we have multiple partners. Everybody knows this, but you have to design an open system thinking about how would you plan for change and how you would deal with unplanned change. So in best practices, we think about designing it with the full system in mind. This is sort of the implementation science best practice part of this. So on the right is this graphic that was adapted by a couple of our colleagues at UNC, but it really came from the interactive systems framework that Abe Wandersman and some others presented back in 2008. And so there's sort of a governing level, which develops funding and policy that pushes it out into the system and frames what a system is supposed to happen, is supposed to deliver in terms of a policy expectation. And then there's how services get delivered on the ground. But in the middle of that is the support system. It's sort of engaging with the governance system to create feedback and communication loops and supports both to the delivery system and also in support of the governing system. So it's a very interactive tri-level system. This support system allows and enables a plan for the full infrastructure and supports needed in prevention systems. It links evidence to practice and delivery, and it also cultivates these feedback and data use loops, and it attends to the interactions within and across each of these levels. Why this is important is that most of us don't design interventions with the full system in mind. We create a policy, we push it down in the communities, we tell people what to expect, and then we say, go do it and let us know what you need. And so we know from implementation science and prevention science best practices that when you guide those systems in a developmental way, focusing on how you support it at each one of these levels, you create a stronger infrastructure and a stronger set of supports all along the way. And you just don't leave it up to whoever decides to participate or who is forced to participate through compliance-driven mandates. So the big picture here is that it's a multi-level attention to do the implementation well. And you are bringing leaders, providers, and support intermediaries, for example, purveyors and support providers into the conversation on the front end. You're not waiting for implementation to happen after you decide all these things. The point in thinking about an integrative governance, delivery, and support system is that when you think about it in an integrative way, you're designing it with this very busy slide in mind. So everybody knows about universal, selected, and indicated prevention. And everybody knows about levels of prevention, primary, secondary, and tertiary. Those levels really speak to where you settle on the populations of concern, and then who gets the services are really the universal, selected, and indicated variables there. So we've given some examples in the slides about what happens at each one of these levels and to whom. I'm not going to read all that to you because we don't have time. What I want to point out is on the left side of this slide is this idea that when you attend to systemic causes of trauma and advantage through a public health model, it builds into, by definition, this notion of equity and inclusion. It's a whole child multi-generational approach. It includes all this different kinds of evidence that I've spoken to. It's very ecological. It crosses all these levels in terms of individual, micro, meso, and macro in the delivery system. It intentionally focuses on de-siloing funding and governance systems, and also the way that services get delivered by building cross-system information, communication and feedback loops, use of data, and how you inform continuous learning. So again, it designs with the full system of supports. So moving into the California discussion, their SIP, their state improvement plan, really has these broad goals that feed into their prevention plan. They want to see connected and strong families. They want to see nurtured and safe children. They want to see families that are free from those things that travel with substance abuse and mental illness. And so, as in many states in their prevention plans, they're focusing on protective factors, reducing risk, building resiliency, and prioritizing things that are data-driven, that they're data at local communities that identify needs, that provide sort of what public health systems call surveillance, and also the necessary supports for those communities to deliver those services well in terms of staff resourcing and attending to biological families. So they're focusing on using kith and kin as opposed to foster care and deep in placements as a driver for their system improvement goals. So a couple key milestones in 2018 as a function of our partnership with the Child and Family Policy Institute in California, which is a lead policy institute for building and installing the core practice model in child welfare. There was a deliberate attention to focus on, well, how can we build prevention into our system as a parallel conversation to helping our child welfare organizations better engage community and families through a core practice model. So there's a whole Directors Institute series of learning environments that have been developed by the CFPIC group in partnership with the Child Welfare Directors Agency and CDSS and other intermediary supports in California, the regional training academies in particular. But in the context of all that work, we convened a conversation supported by the Office of Child Abuse Prevention in 2018, saying, well, now that we've got an updated strategic plan for prevention, we don't really have an infrastructure for delivering it in California. What might that look like? So we had a conversation with a number of child abuse directors, child welfare directors, and human service leaders in California in 2018. And then I left. I came back to North Carolina and said, that was kind of a good conversation. But I learned that they subsequently convened and said, we need to have a summit because we're going to form a prevention cabinet. This excites us. We see a role for child welfare leaders, child welfare directors in facilitating and sharing power in local communities to help accelerate prevention coalitions and collaboratives in each of our 58 counties. So we went back and we kicked off the summit in 2019, which paralleled their ongoing Family First Prevention Services Act readiness building, which, as you know, in each state is a pretty big lift. They also have a Assembly Bill 2083 that mandates local systems of care in California for youth in custody and foster care. But that bill mandates MOAs, which create opportunities to use integrated core practice models between juvenile justice, behavioral health, substance abuse, and the educational and public health systems. So by definition, they're using policy vehicles from FFPSA, from the state legislature, and from their prevention resources in CDSS to drive local prevention planning. They also have embedded some contracts with Strategies TA, Casey Family Programs, Evidence Change, our group, the Impact Center at UNC, to be intermediary supports for this work, and they're doing ongoing prevention summits. Lastly, they are rolling out their ongoing integrated core practice models and doing ongoing work with the Directors Institutes. And I wish I had time, because the most exciting part of those Directors Institutes, in addition to the energy that the directors are investing in the core practice model, is that they've really carved out separate initiatives around understanding race, racism, and the drivers of institutional problems that have driven the California child welfare system into some of the problems that they face today. And so they've carved out special sections on Black and Brown children, African Americans, Latinx, tribal communities, and are thinking about how those conversations and those policies really need to be embedded in prevention in a more progressive way. So a couple of key features of this are that they are paying attention to implementation. They're not just doing this in the classic way. They're focusing on linking state, intermediary, and local capacity building. They're clearly designing this with an idea of long-term sustainment in mind, not just one and done policy outcomes. They're building data, local voice and choice into this planning, taking into account race, equity, inclusion, diversity, and lived experience in the communities. And they're also including grass tops and grassroots perspectives in all this. And I've already mentioned the tribal, racial, cultural drivers of this. Next slide, please. So here's an example of where implementation science and prevention science are playing a role. They're using a stage-based developmental approach to this. This is in the OCAP Strategic Planning Manual. It shows how they're rolling it out through this sort of convening and building a shared understanding. There's a little bit of a collective impact influence here, establishing cohesion and integration at the local county level, building on planning, and then focusing on implementation, managing, and then quality improvement through assessing and monitoring. This is all strength-based, asset-focused, trauma and context-sensitive planning. What I really love about the OCAP, CDSS, all these other intermediary partnerships is that they are going slow as much as federal and state policy will allow them to truly build these partnerships and understand what effective integrated prevention systems have to embed. Now, keep in mind that FFPSA has some very clear timeframes for standing it up. So they have limitations in this work, which is in fact one of the challenges. So if you go to the next slide, I really want to speak to some of the strengths and challenges of this work. There's much infrastructure that still has to be created, particularly in terms of connecting these parts and building the collaborative agreements between each one of these layers in the support system. There also needs to be clear rollout of roles and responsibilities and how to authorize and attend to these roles and responsibilities at each level. But that work is very intentionally happening based on the ongoing guidance and partnerships that the state and these intermediaries have brought into the system in order to attend to this work. There, as every state has, there's mountains of work to do around data management and infrastructure, particularly in terms of using those data to name and define problems and to build the relevant partnerships needed to solve them. And there's much work ahead to pace the implementation, particularly around not getting ahead of local communities, California is a very diverse state. Some of their counties are almost as big as some of our states, and some of their counties are tiny. They're also a very rural state, and many of their states have recognized and unrecognized tribes, in addition to a number of non-English speaking communities. So there's a ton of variation that needs to happen in terms of paying attention to the prevention system in the way that it's being designed. The strengths of this really are, though, that the state understands what it takes in an implementation informed way. And they are really trying to guide this work in a very collaborative, intentional way across these levels of support. And I just really want to stand up the appreciative way. There's amazing work going on. San Diego, Riverside, Oakland, San Francisco, Sacramento. There are places all over California that are just doing ridiculously impressive work in these prevention systems. And it's being co-supported by this tiered level of federal, state, intermediary, and local collaboration, which is what I think effective prevention systems are going to require in the future in order to be successful down the road. So with that, I'm going to stop and turn it back over to Cynthia and learn from the next folks.
Robin, thank you so much. That's a lot to think about, and we really are looking forward to hearing some answers to some questions that are coming through in the chat and the Q&A. Okay, so let's go on and hear from Minnesota. Megan and Nikki.
Hi, everyone. I'm going to start us off and then hand it over to Megan. So we're going to be talking today about some work that we've been doing more broadly across health, human services, and education, really, and how we've taken that work and the body of work that's happening and tried to really focus in on how that work can benefit kids involved in the child welfare system. So, we know, not just in Minnesota, but I'm going to start with Minnesota data, that there is a lot of the sort of relationship between poverty, economic instability, and child welfare, right? I think that's a pretty well-known fact that families that are living in poverty, experiencing economic instability are much more likely to be involved in the child welfare system. That's likely for a lot of reasons. They're more likely to be in systems where they're being monitored, more likely to be reported, all of those things. And so we've done some sort of starting to explore that in our data in Minnesota. And there's some patterns that are emerging that we think are interrelated that we sort of like to talk about today, and what we're doing to try and address it. So we have recently looked at data that shows that in census tracts with high rates of childhood poverty, those census tracts also have higher rates of reporting to child protection, and in particular, higher rates of reporting for neglect. In Minnesota, we have very significant disparities in both our in racial disparities or disproportionality in our child welfare reporting, but also, they're also at the point of screening and foster care entry, for that matter. It really is a cascading impact down the line. And in addition, we have pretty significant disparities in by race of children living in poverty. So American Indian and African American kids are 6.4 and 5.4 times more likely to live in poverty than white kids. So just sort of setting the stage of what's happening here. And so this is the data showing you that census tract data that I talked about. And so this is the data really specifically in Minnesota that we have been able to demonstrate. Each of those dots as a scatter plot is a census tract, essentially, and it's showing the relationship between the percent of kids living in poverty and the reporting for neglect. And we know this isn't true in Minnesota. So Chapin Hall has been looking at related data and research from across the nation that really, and they have a brief and a slide deck that I think we're going to send a link to, so you guys can take a look at that too. That really highlights how things like reduced TANF benefits, reduced childcare assistance, housing instability, reduced employment or economic supports have been like, they have a direct linkage. There's a fair number of studies, even something I think that we wouldn't consider, right? But an increase in gas prices has been shown to have an increase in child welfare reporting. So when we reduce the economic supports of families, what we see is a corresponding increase in child welfare involvement. And I think the sort of point that we want to make from that, or what we think that highlights, is that this isn't actually a function of an individual family level issues, and addressing it at that individual family level is really not going to be enough if what we're trying to do is impact child welfare involvement and do the sort of more comprehensive prevention work. And so we really need to start thinking about how we're, I think really aligns with what we heard from Robin, really about addressing it at that multiple levels to reach families in economic distress before they get to that sort of family level distress or trauma. And so with that, I'm actually going to hand it over to Megan to talk about that continuum a little further.
Hey everyone, next slide, please, Jonathan. Thanks, Nikki. Yeah, so in Minnesota, we've been really focused on using this continuum to promote family well-being and prevent families from ever touching the child welfare system at all. The research that Nikki talked about is what we're currently working with. And we would also point you to, again, that critical information being gathered by the folks over at Chapin Hall. And I also want to say, if we're paying attention to my dog, evidently, if we're paying attention to Maslow's hierarchy, we know that basic needs are the first level of well-being for families. And unless basic needs are met, it's particularly difficult for parents to parent and families to family. And so it's critical that we have strategies at multiple levels to help support different pathways. And because we know that families don't come in pieces, there are multiple strengths and needs, and that each point of this continuum connects with every other point. So when we're talking about prevention, we're talking about building multiple pathways for families and communities to get what they need to thrive. And it's critical to support strategies at multiple levels. I think the thing that we've noticed about prevention, especially as we're looking at this continuum, is that even with an intervention, there's something being prevented. And with children and families, this often moves us into an intergenerational conversation. But I think what we're trying to get at is that we believe that this prevention continuum is situational, especially when we apply it to the child welfare and child protection continuum. So this means that we can think of it in multiple ways. So we can think of it before a report, which is primarily where we're working. How do we work at the population, at the community, and at the family levels to prevent a report from even coming in the first place? But we can also kind of lift this continuum up and put it on different parts of that child welfare continuum. So after a report, during assessment, child welfare services, out-of-home placement, et cetera, because we're always going to be preventing further distress for families. And we're often talking about upstream services and that we need to move upstream. And it's really hard to know what that means because it means different things to different people, just like the language around primary, secondary, and tertiary prevention. And so with this continuum, we've tried to break up that language a little bit. So promotion really working at that universal policies and systems level. So for those of you who know the social determinants of health framework, that's really that leftmost big P policy side of that framework. The prevention level really working at that community level. And then early intervention working to promote strengths and mitigate early risk one-on-one with families. So this is what we're talking about when we're talking about upstream and prevention services. So as most of you know, opportunities come when they come, and sometimes you go for one thing and hope it will fit together with the other. And this was fortunately the case for us as we applied to a national technical assistance opportunity with 4 national partners, ACF, Prevent Child Abuse Minnesota, Prevent Child Abuse America, Annie E. Casey, and Casey Family. These 4 partners are working with states to move toward prevention of maltreatment as the norm. And while this slide is coming prior to our preschool development grant slide, it's important for us to note that the work we're doing with Thriving Families really does build off the work that was already happening through our preschool development grant and is working at 2 points in the continuum we just showed you. So promotion, that kind of big P policy area, and prevention at the community level. And you can see on this slide that we're working on policy and practice, as well as building access to critical services, especially those concrete supports. Our working goal for this project is to define an advanced policy and practice changes that reduce unnecessary involvement of Black, Indigenous, and children and families of color in the child protection system, and instead equitably connect families to services and supports that will promote child and family well-being. And we know that the child welfare system can't do this by itself. And we need an interdisciplinary team, both at the local and state level, to help build the most flexible pathways that will work best for families. That brings us to our preschool development grant in Minnesota. Our PDG planning really focused on community engagement so that we could build a strategic plan that's relevant for families and communities. You can see here that families and providers were feeling as though programs and supports were not easily accessible. We also heard that sometimes families asking for what they need can result in punitive measures, surveillance, and especially for Black, Indigenous, and families of color, reports of neglect and maltreatment. PDG also supports our ability at the state and local level to focus on building those multiple pathways through collaboration, coordination, and communication at the state and local level. To that end, Minnesota is supporting 13 community resource hubs and site partners to provide relationship-based, culturally responsive service navigation for families. And you can see on this slide some of the different quotes from families. There's so many hoops. Look at employment strategies holistically, create a system to work for individuals, families, and communities, not retrofitting families and communities to systems. We want to make a system trauma informed. Again, it comes to trust. There's not trust for communities of color and Indigenous communities. So really hearing that families are wanting something within the community accessible to them. As I said, in Minnesota, our PDG grant is supporting community resource hubs, both through early intervention, navigators working one-to-one with families, prevention. The PDG hubs are located within existing community-based organizations that work to create feedback loops between their communities and state agencies. And promotion, so feedback loops with those hubs provide meaningful input for practice and policy change. The hubs have a lot of different models: community action agencies, tribal organizations, counties, community child care centers, and more. And they all offer navigation as well as several supports and services. To foster relationships, networking, and reciprocal learning, grantees and state agency partners participate in monthly communities of practice, quarterly networking meetings, and reflective mental health consultation. So our preliminary learnings include that the most frequent services sought by families are financial assistance and benefits, childcare needs and access, food, housing, and healthcare. Hub staff have received training on equity-oriented services, trauma-informed reflective consultation, and statewide systems like Help Me Connect, Minnesota Benefits, and Bridge to Benefits. Hub grantees have continued and contributed to the improvement of statewide systems and tools, and hubs have built capacity for trauma-informed approaches through participation in the mental health consultation. And finally, just want to point out that hubs are a critical way to support access for families at that local level. And we hope to be able to define in the future a relationship between helping families get what they need and reduced rates of neglect and maltreatment reports. And this slide just really shows what families have been asking for in the second and third quarter of our work. And you'll see financial assistance and childcare are the most heavily requested. When we talk about successful referrals, we mean those referrals that we know families have been able to access. And so the navigators and the hubs are really following up on those referrals. And then one of our most critical points is that the hubs are serving a greater percentage of Black and Indigenous families than their respective populations in the state. So with that, unless Nikki has anything else to add, I think we'll say thank you for the opportunity, Cynthia.
Thank you, Megan and Nikki. This is really great. Somebody is asking how we could get more information on the hubs, so I'm going to ask you guys to answer that question when we get to the Q&A. This is exactly why we're here, is to share the kind of information that people can take back and use. So thank you both so much. We'll hear a lot more from everybody later during the Q&A. All right, so moving on, our friends from Washington here, Sarah and Alyssa.
Thank you so much, Cynthia. I will start things off and then hand it over to Sarah. So next slide, please. So we are here to talk about the Plan of Safe Care in Washington. We are right in the middle of statewide implementation, but this slide goes over a little bit about how it started for us. Those of you who are familiar with the Plan of Safe Care, this might sound familiar to any work that you're doing in your states. But back in 2016, with the launch of the CARA legislation, the Comprehensive Abuse and Recovery Act, there were some changes made to CAPTA legislation, which is where the Plan of Safe Care lives. CAPTA is the Child Abuse Prevention and Treatment Act. And what those changes did is further clarified which infants require a plan of safe care, essentially changing it from infants who are prenatally exposed to illegal substances to infants who are prenatally exposed to any substance with abuse potential. So that broadened the population that required a plan of safe care. Prior to that, in Washington, the plan of safe care was something that lived within child welfare. But now we're seeing with this, the impacts from the CARA legislation, that plenty of families will require a plan of safe care that do not require child welfare intervention. So a couple of the other pieces that changed with this federal legislation was some data that states needed to report to the federal government around the plan of safe care. And the focus shifted a bit so that the plan became more family-centered and then focused on the needs of the infant and the family and or the caregiver in order to safely parent and meet the needs of that infant. And then there was some language around how the monitoring needed to look and oversight from the states. And so we'll get into a little bit of that. So what we needed to do is do some work around defining the language in CAPTA. We partnered with Children and Family Futures for some in-depth technical assistance, and they really facilitated and moved forward this work, which included several years of gathering with stakeholders in the community and across other agency partnerships, and worked together to define these definitions in the CAPTA language, which we had to define the statement affected by substance abuse, withdrawal, and FASD. So we had to come with agreement with what that meant for children and families in Washington state. With that, with those definitions, we needed to determine which infants required a notification and a plan of safe care and which infants required a report and a plan of safe care. One of the things that our work with stakeholders and one of the pieces that we decided to move forward with in implementation is that we would have two pathways for the plan of safe care, a child welfare pathway and a community-based pathway. So those infants that required a notification, that's really around notifying child welfare, some data pieces, but receiving the plan of safe care in the community. And those requiring a report is the typical way that infants where there are safety and risk concerns are reported to child welfare. And then the last piece of that, all that work with stakeholders was to figure out how it would work, that we would oversee this work and work their implementation. So with those definitions, we determined in Washington that any infant with prenatal substance exposure, any infant affected by withdrawal, and that's when you see those behavioral and physiological features that are a result of prenatal exposure in utero, and then any infant with fetal alcohol spectrum disorder. These are the infants who require a plan of safe care in Washington. So when we take a look at all the infants that require a plan, then we had to look at which required a report to DCYF intake. So this is for child welfare intervention. And essentially what we did is did not change much of that criteria at all. Still, if there are safety concerns or imminent risk factors that could lead to imminent risk of harm if the birthing hospital identifies these sort of situations. Just as before we started this implementation, they will still be calling a report to child welfare. But a couple of the areas that we were able to identify and really make more clear with these definitions and defining the notification versus report pathways is, you'll see in bold, infants exposed to marijuana only do not require a report. So that is something that we found in our initial work with stakeholders and taking a look at our data around intakes, that we were screening in families where there's prenatal exposure to marijuana, not consistently across the state. Some areas were screening them in, some areas were not. Some areas had higher incidences of intakes being screened in with Black families and Native American families compared to white families. So we really wanted to make sure that those pieces were very clear, because we weren't approaching them consistently as a state prior to this. But essentially, the families that require a report for our intake workers to do their risk assessment are when there are safety concerns identified, when withdrawal is a result of exposure to illegal substances or misuse of prescribed substances, and when there's ongoing evidence of substance use that creates some safety concerns for the infant. So notifications, the families that will receive their plan of safe care through the community-based pathway, are situations right now. There you can see 4 really great examples on the slide, but these are families that were not receiving any sort of intervention or support or resources prior to the launch of our plan of safe care. So we're hoping that with this community-based pathway that we're capturing some families that were otherwise not receiving any kind of support or very minimal support. And so that's families where the healthcare provider is able to verify, in the instances of MAT, medication-assisted treatment, they're able to verify with the clinician that the parent is taking the medication as prescribed and following the treatment plans. When it's prescribed opiates, they make that quick verification with the prescribing doctor just to make sure that there's no concerns around the parent taking them as prescribed or not. So as you can see, the healthcare providers are taking some steps to verify what is being reported to them by the family in order to determine which is the likely route, what information they need to include in the referral that helps determine that report or notification route. So when the hospitals, so the birthing hospitals submit a referral, they determine if a report or a notification is indicated based on the information that they provide. We have a great, through our partnership that Sarah will talk a little bit more, we have a really great online referral portal that the birthing hospitals are using here in Washington. And they input information about the family, some de-identified data that gets into that data reporting piece, and answer those questions about safety and risk concerns. And they're either directed to make a report to DCYF, or for infants that don't require a report, they are directed then to a screen where they fill out a referral to Help Me Grow, who receives the plan of safe care, this referral, through the referral portal, and engages with the family. And so this is our community-based pathway, and Help Me Grow supports the parent to identify, access resources and supports, and the family is connected with appropriate providers to support them. And I think next slide, please. I will be handing it over to my partner, Sarah.
Great, thank you, Alyssa. So as Alyssa outlined, Washington developed a community-based pathway for families receiving plan of safe care notifications and selected partnership with Help Me Grow Washington as the approach to connect the families in this pathway to resources and community support. So I just want to spend a minute, for those who are unfamiliar with Help Me Grow, it's a systems approach really rooted in community to connect young children and their families to the resources they need. So in other words, it's this network of people, partnerships, processes, and some technology all coordinating together to best support providers and families in navigating the really complex early childhood system. Help Me Grow is a national fidelity-based model, and last I checked, 29 states are implementing Help Me Grow systems, which are highlighted here in green. And in Washington, the state affiliate is Within Reach, which is a long-standing nonprofit organization with just deep expertise in building pathways to make it easier for families to navigate systems and connect to services they need. So specifically in the context of the Plan of Safe Care, this is how Help Me Grow works, and just a subset of the resources a family may get connected to. So when a referral from a birthing hospital comes in for a family with a Plan of Safe Care notification, Help Me Grow Washington's navigators reach out to the family, ask questions, listen to their needs, and work alongside the family to connect them to appropriate resources that meet their needs. And of course, that looks different for each family, right? But such supports could include application assistance for health insurance, or help finding a nearby food bank, parenting class, perinatal peer support group, or a low-cost medical clinic. Support may look like warm handoffs to specialized community-based or health providers, or a referral to early intervention. But ultimately, this new Plan of Safe Care referral pathway to Help Me Grow offers a community-based response to provide wraparound services and support to families who would traditionally be routed to child welfare or who are currently offered just minimal resources or no resources. So it's pretty exciting. Okay, so I want to talk highly about the online portal. This is one innovation born during our state's Plan of Safe Care development. And it's this build out of a secure online portal that meets three specific needs. One, it collects data required by CARA legislation. Two, the portal's algorithm supports the birthing hospital's decision around when to refer to child welfare, when to refer to Help Me Grow. And thirdly, it facilitates a streamlined process for birthing hospitals to refer families to Help Me Grow. So I want to take just a quick look at how this portal is designed in case this is something interesting to you and your state. So this diagram illustrates the portal's high-level process flow. It's much more all nuanced but for this. Okay, so once a healthcare provider at the birthing hospital identifies an infant as substance exposed, they access the portal, which is essentially a secure web form. And the provider first provides de-identified data on the substance exposed infant, which automatically gets sent to DCYS. The algorithm then asks the provider questions about safety and other child welfare intervention criteria that helps that provider determine whether a report to child welfare is required or if a notification to Help Me Grow can be made. If the infant does require a report to child welfare, then the provider is instructed through the portal to call DCYF intake. So that's no change, that's how it's always been done. But if a report is not required, the healthcare provider completes the Plan of Safe Care, and with proper consent in place from the family, the Plan of Safe Care gets automatically sent to Help Me Grow along with the family's contact information. Help Me Grow will then reach out to the family to begin the care coordination process, and Help Me Grow is also keeping data onto what services and resources the families were referred, and will loop back with the family to determine if services were received. So Liz and I just want to spend the last couple of minutes talking through what our implementation has looked like thus far and some of the key lessons learned along the way. So with implementation, a group of cross-sector partners are driving the Plan of Safe Care rollout in our state. DCYF is coordinating with state-level agencies. Our Department of Health and Healthcare Authority, which is our Medicaid agency, in particular, have been strong partners, as well as the Washington State Hospital Association and other statewide organizations, and then many community partners and providers. So all of whom are really working together to think through implementation and next steps. We launched 2 initial pilot sites in June of 2021. And as of this past December, 13 additional birthing hospitals across the state were invited to join the pilot work, and they're now at various stages of implementation. These 13 hospitals were invited because they were primed as they are already engaged in quality improvement work with the Washington State Hospital Association, and they're working with the Department of Health to address substance use disorder in pregnancy. COVID has slowed our timeline a bit, but we are hopeful to get to statewide implementation by end of this year. So while our team is working with hospitals to orient them to the new process, Help Me Grow in partnership with DCYF and other Plan of Safe Care system partners, they've been busy developing the necessary infrastructure to support the Plan of Safe Care work. In addition to the online portal build, Help Me Grow established a small team of mental and behavioral health navigators to provide tailored care coordination to families with plan of safe care notifications. And this team has also gathered over 1,000 resources across the state to add to the already robust Help Me Grow statewide resource directory. So lots of great progress, but we're not done yet. We are in the midst of still trying to figure out connections from our statewide Help Me Grow contact center to local Help Me Grow systems in place. We are exploring partnerships with statewide organizations specializing in perinatal mental health and parent coaching in order to offer, a fuller array of services and supports to families. And at the community level, we are working closely with health and community-based providers to tailor the plan of safe care process to complement what already is in place in their communities. So I'm going to hand it off to Alyssa to go more into that as she covers our key learnings.
All right, thank you, Sarah. So one of the things that we have found is it has been really helpful and successful when we've had the opportunity to be really intentional about meeting the communities where they are. And so as we've started this expanded launch by inviting the 13 additional birthing hospitals to participate in the referral portal, what we have done is through our relationship, so in the context of this cross-agency partnership with our partners at the Department of Health and the Healthcare Authority and the Washington State Hospital Association, and us, our work here at DCYF, we are reaching out to the hospitals and other organizations in the community that are already engaged in serving families in this capacity in a community-based way outside of child welfare involvement, probably agencies and organizations that are also working with families served through child welfare. But what we're doing is bringing together these collaborations. Maybe there are strong collaborations that already exist in some communities, and in other communities, they might be collaborations that are just being built up. And we are hoping that our work with the Plan of Safe Care and implementation and the behind the scenes coordination that Sarah just described, especially between our statewide Help Me Grow affiliate and any local Help Me Grow networks, that we're supporting that and helping to provide some infrastructure and even a higher level of coordination for the plan, for the families that require a plan of safe care on that community-based pathway. So that looks different in any community. It could look very different. And so, like Sarah mentioned, we are tailoring this work to what the community needs, what's already happening in the community, and the needs of the partners in the community. And then the other biggest thing that we have learned that has just been crucial is we started all of this implementation during the pandemic, and we are working with hospitals that are often overwhelmed at various stages of our implementation. And so we have approached our communication with our partners at hospitals very intentionally, as well, as far as they can take it on when they're ready and when they are able to implement something new and learn about a new process, that we're there to support them to do that, but that there's no pressure, because we know that all of our hospitals are being overwhelmed by much higher priorities right now, and that their birthing centers may not be able to take on even just a small shift in practice. So that's the other thing that we've just been really intentional about in supporting our partners in the community. Okay, thanks, everyone.
Alyssa, okay. All right, wonderful. Alyssa and Sarah, thank you so much. This is such an exciting intervention that you guys have developed, bringing both of those two systems together. And we've got a bunch of questions for you too. So let's take the slides down and bring all the presenters on the screen. Okay, great. Thanks, I think we're all here. All right, but the one thing that I really miss, well, I miss a lot about not being in person, but one thing I really miss at times like this is the ability to applaud. So, because I would really love for you all to hear some applause, I would love to give you applause, because it was really, it was just a terrific set of presentations, and we have a lot of questions. But before we start with the questions that we've received, I just want to ask you guys, as you were listening to each other, what did you hear from either of the other two presentations that really resonated with you, that you said, oh yeah, I know we went through that, or yeah, we thought about that and this is what happened, or we look at prevention the same way, or whatever may have struck a chord with you from your fellow presenters? And anybody can start.
I can kick kick us off. And thinking about Minnesota, just that I resonated that many of the needs we're seeing from families right now is basic needs, and how critical that is to really wrap our heads around how to best provide that at both a systems level and at a family level. So I really appreciated that frame. And then I think also, in listening to Robin, I think we're seeing Plan a Safe Care and the partnership with Help Me Grow as a public health approach to child welfare. And Alyssa could probably speak way more intelligently about that than me, but those were two parts that really resonated. So I learned a lot. Thank you.
That's great. Anybody else? Robin, I'm wondering if you have a thought about Sarah and her comments, what resonated with her?
Well, you know, it's common to say nice things, but I tell people I'm old and just say what's on my heart. And I love both presentations. They were really informative, and the kinds of hard work it takes to do the research and figure out how to adapt these interventions to each state or each jurisdiction or place where you're trying to do it. There's just an incredible amount of stuff that goes on in the background before it gets to be the it. And what I heard in both places was a really serious intentionality to take into account best practices, not just in terms of an evidence base for coming up with something that's really going to help, like in Minnesota's cases, as Sarah just mentioned, is focus on really just trying to think about getting people in a place where they can receive and appreciate supports and services, and then make use of them in an adaptive way. But also in Washington, where they have taken and sort of customized and adapted an evidence-based program to not only think about mandated services, but preventative services in a public health format. So again, great stuff. And I heard implementation science infused in both approaches all throughout. And I just want to congratulate. It's good stuff.
Great. You're getting smiles, so I think that your congratulations is appreciated. If I can speak for everybody. Okay. All right. Did anybody else want to come in about your presentations? Otherwise, I'll get to the audience questions.
I'll just quickly say, I mean, thanks, Robin. And I do think the way you talked about the sort of open systems approach and having to address it at all levels really speaks to what we've heard and felt from families, from communities, honestly, about how we have to do this work. And when we think about the community hubs that we're talking about, it really is working with those communities to identify the policies and practices that serve as barriers to them getting the needs, the sort of meeting the needs of the families that they're serving. And how do we keep that feedback loop open so that we're able to, at a state level, think about the coordination supports that need to be put in place, the policies, the barriers that need to be removed so that we can actually do these things to get families what they need. So that also spoke to me, and I think I saw a lot of interplay there.
And can I just comment, Cynthia, on that? Nikki, that is such a really poignant and important part. One of the mistakes so many people have made in trying to roll out policy is that they will try to do the right thing. They'll go into communities and they'll say, we need you, and they'll try to recruit common voices and key leaders and people with practice and lived experience. And then they'll build their action plan or their strategic plan, and then they'll walk away. So they won't build that recurrent feedback loop. How are things landing? What did we get right? What did we miss? What data are we not really paying attention to that we probably should? So this ongoing incorporation of community voice and lived experience in local implementation, even if it's designed at the state level, is a critical point that you're making. And I hope people are listening to that.
Yes, absolutely, for sure. I was making some notes while you guys were presenting, and one of the questions that I had for you is if you had to just say what is one really critical, essential element of any prevention endeavor, shall I say? I don't want to call it a program, but any prevention endeavor. What would you say? And I was thinking that maybe these feedback loops were part of it. Certainly being located out in multiple communities, which is the case with the hubs, it's the case with the Help Me Grow, is part of it. But anyway, I don't want to answer my own question. I'm just wondering if you had a thought about what might be something essential that you would pass on to everybody, like if you do anything, do this. What might that be?
think it's too late, Cynthia. Too late. You answered your own question. No, I mean, I really do agree. I do think that engagement with community and that continuous feedback loop with community to inform the work you're doing is critical. I highlighted in some of our data that we have significant racial disparities in Minnesota, pretty much in every indicator that like pick one out of a hat. It really doesn't matter. You're going to see disparities for Black, Brown, and Indigenous kids and families in Minnesota. And so we have to be engaging those communities to design and to redesign really a system that actually works for them, because clearly the systems I think that we've put in place are as designed are doing what they intended, and that is to create racial disparities. So we have to include those voices in anything we do, and it has to be designed with those families and those communities, because the people that have been in power, that have been designing these systems, are doing it in a way that benefits people who look like them, if we're going to be honest. And so that changes how we, I think, have to then think about how we design systems.
Great. I see some nods, so your fellow presenters here are definitely agreeing with you. So while we're talking with Minnesota a little bit, you have some questions here that have to do with the hubs. And people want to know how the hubs are interfacing with other community organizations, other kinds of organizations that are out there. Once you put a hub in a community, do you put a hub in there, or do you develop one that's already there? And what's the relationship between it, whatever else is going on already in that community?
Sure, these are all great questions. And we like to say, if you've seen one hub, you've seen one hub, because they really are working within their regions and communities to build those partnerships. And so it's never a replacement for the county, and because we are state supervised, county administered, there's not a real way to replace the county. But I think what the hubs are able to do is connect families with services that doesn't feel like, if I walk into this building, someone's gonna end up taking my kids away. And so I think that's one thing that the hubs are able to provide, even though they're not a child welfare specific prevention effort. And so just wanted to put that forward. They're not meant as a replacement. They're meant as a place where families are already naturally going, or that is convenient for families to go, to find someone who looks like them or speaks like them, to help build a pathway. Just to help build a pathway.
Beautiful. Thank you. So we have some questions here that are for Robin. One of them, the first one, Robin, that came in during your presentation was, where do economic and concrete supports fit in with the work you're doing in California? We heard this theme in multiple presentations, that prevention efforts really have to consider economic and concrete supports. And so we have a question here for you about that in your work in California.
Sure, it's a great question. I mean, anybody that's been any time in the human service systems, no matter what door you come into, recognize that families are under stress, and economic stability and the kinds of conditions that create safety and being able to focus on child development in a positive way have to be attended to. And child welfare directors are keenly aware of that in California. They understand that. So there are a number of parallel organizations, First Five, there are family resource centers, and a host of partnering agencies in California that continue to lift these ideas up, that economic, health, public safety, all these things that attend to family wellness have to be in the equation. Every county, of course, is going to be different, because some of the counties are quite large and they're resource rich, and others are quite rural, and their child welfare agencies are like, a director, one supervisor, and 2 or 3 staff. They're just tiny places. So it's in the equation. I can tell you, I can guarantee it's in the equation. It comes up in the prevention planning meetings with the local community coalitions, and it's also part of the data platform plan that FFPSA and the state university systems are trying to attend to. when they think about dashboards for local community wellness. So it's in there. It's very developmental, but it's in the equation.
Great. Thank you for that. And then Robin, I have another question from a very specific question for you. Someone would like to know, and I think I know who this is that asked this question. If the California Emergency Child Care Bridge Program is involved with you in the California Prevention System planning.
I want to say a qualified yes. I know that they've been interacting with CFPIC, the Child and Family Policy Institute in California, who have been hosting and facilitating local groups. They do a number of programs around differential response and other things. And so those groups are intimately involved in the local planning systems, but I don't know about it at the state level. The one thing I am unsure of is whether they've got a representative voice in terms of their engagement with CDSS. So I know they're doing some stuff locally, but I do not know about their connection to CDSS.
Well, that's okay, because as luck would have it, they will be presenting at the 4th seminar in April. So good. Just putting a shameless plug in there for you. Okay, so now I want to ask, have a little bit of a conversation, because we had a number of questions for Sarah and Alyssa in regards to how the decision is made, whether you do a notification or you do a report. I think that's the gist of the questions about who makes that decision, how does it get made? Can you guys talk a little bit more about that?
You want me to take that one, Sarah? Okay, so one of the pieces that we have integrated into our implementation is to increase training and support and be a resource to our partners at birthing hospitals in terms of their role as mandated reporters. So I think both Sarah and I mentioned that really nothing has changed with the implementation of Plan of Safe Care in terms of birthing hospitals making reports to CPS, to our DCYF intake line. What has changed is that we have now this voluntary community-based pathway. So in the training and support that we are offering to all of our birthing hospital partners, we're also providing them some guidance and support around how to have transparent conversations with families to discuss the potential of both pathways, and that at that time, no one is essentially determining what pathway happens, but we encourage the hospital nurses and social workers in the birthing center to gather information and talk with families about their situations, including what kind of services and supports and the kind of information that they are already, and conversations that they're already having with families to determine prior to the two pathways whether or not they needed to call DCYF intake. So those pieces are still the same. We're just supporting our birthing hospitals with some more regularly occurring education and tips around having transparent conversations with families, which includes making sure that they're educated as providers themselves on what both those pathways look like. So that could mean that sometimes as mandated reporters, they know they need to make a report, but really can't speak to what happens after they make a report. So we're also providing them with that information so that they can speak really transparently with families about the potential of either pathway. So those are some things that we're doing. And then when they use the online referral portal, the algorithm that Sarah talked a little bit more in depth about, it really does help direct that. So initially what we needed the referral portal to do was gather all of the de-identified data that we knew we wanted to collect on any infant in our state that was born substance exposed. And after that happens, after that information is gathered, then the referrer from the birthing hospital is asked a series of 5 questions that really get to whether or not there are safety concerns or risk factors in place that might indicate an imminent risk of harm to the newborn. So if any of those 5 questions is answered with a yes answer, they're redirected to call the DCYF intake line. If they get no's for all 5 of those questions, then that's when they're redirected to the referral for Help Me Grow. Help Me Grow, the community-based plan of safe care pathway through Help Me Grow is voluntary for families. And so since that, the process of gathering information about the family situation and looking into whether or not there are safety or risk concerns, since that has already happened, we know those families don't require a report to DCYF. So at the time of the Help Me Grow referral, participation in the plan of safe care through the community-based pathway is entirely voluntary. And if they decide not to participate, it's not like then they're referred to CPS. It's just it's a group, like I said earlier in the presentation, it's a population in our state that's not currently receiving any sort of intervention. So they still have the option to not receive an intervention. But we're hopeful that with our education and support to birthing hospitals who are having these initial conversations with families, that they have a clear picture of what both those pathways could look like for them, and that they would be encouraged and enthusiastic about participating in the Help Me Grow pathway. The other piece around that is we haven't gotten very far on this, but we're also hoping to branch out and provide this same kind of education and support to substance use disorder providers, MAT providers who are encountering these women, families when they're pregnant, so that they can talk about the plan of safe care in a way that as a provider, they feel confident and understand it enough to be able to talk about it with the pregnant person and talk about what those pathways and options could look like. And this is for the future, but we're also really hopeful in Washington that our plan of safe care work will expand into the prenatal realm as well.
Wonderful.
Hopefully that answers.
Yes, you did. You answered some questions that are in the chat that I didn't even ask as a part of the original question. So hopefully everybody who put something in the chat around this question got it answered. That was very thorough. Thank you so much. Thanks very much. I think it's really important for people to understand that there are multiple pathways and that there's voluntary participation. So this is important. So thank you both. I'm just wondering if, Nikki, I can put you on the spot because we had several people ask about the relationship between gas prices and child welfare referrals. And given what's going on right now at the pump, should we be worried?
Yeah.
Okay.
I think it's a really interesting thing, actually. So this that study, it was a research study. It was a statistical analysis, with looking at control variables. And what the study found was that with a $1 increase in gas prices, there was a corresponding, I think it was somewhere around 650 per 100,000 kids increase in child protection reporting. So that's really reporting. I want to be clear. There is a difference between reporting of child maltreatment and actual incident of child maltreatment. So we should make sure we're distinguishing those things, I think, when we talk about them. So that's one thing. But I think the general story is really that when families are under economic strain, we do think that there's reduced capacity for parenting. We all, right, like myself, everyone included, aren't at our best when we have multiple stressors layered on top of us, and that can result occasionally in increased child maltreatment rates. Now, I am terribly worried about what's happening in our world right now and the sort of economic landscape for families and how that might impact children's experience, I guess, of child maltreatment. That's really what I'm worried about, not necessarily the reporting of it and how that, there's also an impact on the child welfare system that's different that I think we have to think about also, but I'm so I say that, but I also nationally in the pandemic, we saw huge economic increases in economic stressors and a real reduction in child maltreatment reporting. Mm-hmm. Now, of course, the reason why we think that happened was that children were less likely to be in school, less likely to be seeing their doctors, especially in the first 6 months of the pandemic. I think that's not been as true as much in the last half of it. But they weren't seeing those people that are mandated reporters. They didn't have, there weren't as many eyes on kids and families as there were. And so we think that was what was partially driving the reduction in child maltreatment reporting.
Yes.
I have very personally mixed feelings about if that's a good or a bad thing, because especially, at least I'll just talk about Minnesota data. We know that there's over monitoring of Black, Brown, and Indigenous kids and families. That reduction in the over monitoring of those families may not actually be a bad thing. there are, so like, you'll see, I'm not wholly comfortable saying that like we might be missing child maltreatment in families and that that's not a bad thing. And yet the child welfare system is itself inherently traumatic for families. Any intervention by the child welfare system is itself a trauma for a family.
Yes.
And for a child. And I don't know that we as a country, as a society, have found the right balance between how much, again, this is crass, but how much maltreatment is okay or better than a sort of traumatic intervention by a system, right? Like balancing those things, I think is at the heart of what we're constantly trying to do in child welfare. And why we think that if we can put the supports, right, in an ideal world, we'd have the political will to make sure that families could afford stable housing, they could have access to food, they had reasonable employment, access to the childcare that met they need. And I guarantee you, if we did all of that, there would be good enough parenting. So what someone just sort of put in the chat, like that would happen. It would be good enough parenting if people had all of the access to resources they need. That would be the ideal thing. Well, I'm talking too much probably. I want to move on with other people, but I think it's just, this is a complicated sort of balance. And I think our system's involvement is problematic also, because no family is like, hey, let me be involved in a system so I can get my needs met. That's nobody thinks that's ideal. Nobody wants a system there to help them take care of their kids and meet their needs. We want to develop a society, a government structure that does that without systems having to intervene with individual families.
Awesome. Well, we can always count on you, Nikki, to speak from your heart and to not be shy. Love that. Thank you so much. You raised a lot of questions. A lot of people are commenting in the chat here, and appreciate particularly your comments about over monitoring. So we have 1 minute. Would anybody like to make a 1 minute final comment, a thought, a feeling?
Well, I'll just very quickly appreciate Nikki for leaning in with all of that. So incredibly important to think about it. And I think this is the chief reason why prevention systems, even getting away from that word prevention, need to be focusing in communities around how do we nurture and enable well-being systems. And these systems really are a combination of informal and formal supports, not something the state does or the county does. We really need to redefine what we mean by raising healthy children and families in this country. And the way that you just outlined the problem is a key driver for why it's so important to do it that way. So thanks so much.
Wonderful. Perfect. Thank you for ending us on the note of child well-being. I appreciate all of you. Again, I wish we could give you some applause. I'll just give you some here. And just want to, again, thank you all for your presentations and your giving us your time and your thoughtfulness. Want to appreciate also the people who have participated in as our audience, and we hope that you learned something and that you found it stimulating and enjoyable. We do have a survey coming up, so please fill out the survey. We want to let you know that the recording and the slides will be available on the website shortly. I'm not sure exactly how long, but give us a day or two and they'll be up there. So again, thanks everybody. We appreciate you. Bye-bye.